Good morning. My name is Andy Luchter. I'm a professor of psychiatry at UCLA and director of our Neuromodulation division. It's a rare privilege to get to introduce a speaker who has helped to build the foundations for a whole branch of psychiatric research and practice. I have that privilege today with introducing you to Dr. Harold Sackeim. Harold is a professor of clinical psychology in psychiatry and radiology at Columbia University. For 25 years, he served as chief of the Department of Biological Psychiatry at the New York State Psychiatric Institute. He's a world-renowned researcher on mood disorders in general, and I first had the pleasure of getting to know Harold as a fellow co-investigator on the STAR-D study, the largest study of depression ever undertaken in the US. He had a big hand in design and execution of that study. And his work on electroconvulsive therapy beyond that study has really been groundbreaking in our field. He's helped to elucidate the mechanisms and enhance the safety and efficacy of ECT treatment across the world. He's the founding editor of the journal Brain Stimulation, and in this role, as well as in his leadership of the International Brain Stimulation Congress, he has helped to build the entire field of neuromodulation. Harold has had a distinguished career, which started when he received his bachelor's from Columbia University, and a second bachelor's and a master's from Oxford University. He went on to receive his graduate degree from the University of Pennsylvania, where he completed his clinical training in psychology in the Department of Psychiatry. He joined the faculty in Columbia University in 1977. Harold's research has focused on the neurobiology and treatment of mood disorders. He's made contributions really too numerous to count to our understanding of the pathophysiology of major depression and mania through the use of brain imaging techniques, as well as through examination of the role of lateralized brain function in normal human emotional regulation, neurologic disorders, and psychiatric illness. He's perhaps best known for his 3 decades-long research into electroconvulsive therapy at Columbia University and the New York State Psychiatric Institute, where he really helped to elucidate some of the fundamental mechanisms of ECT, ways to enhance its efficacy, comparisons of unilateral versus bilateral treatment, as well as methods to enhance effectiveness of the treatment, as well as safety. He's the inventor of magnetic seizure therapy, a new form of brain stimulation that is now in development through clinical trials. Has had a hand in a whole host of brain stimulation treatment studies, including those on deep brain stimulation. Other studies he's participated in include vagus nerve stimulation and other non-invasive methods as well. Dr. Sackeim is a member of the editorial board of a number of journals. He's been honored by the National Association for Research in Schizophrenia and Depression, NARSAD, the American College of Neuropsychopharmacology, the American Psychiatric Association, and many, many other professional organizations. He's the author of more than 400 articles in the area of psychiatry, particularly focusing on treatment of mood disorders with brain stimulation techniques. And I'm delighted that he's here today to do this Grand Rounds presentation, looking at the role of brain stimulation therapies now and in the future in the treatment of neuropsychiatric illness. With no further ado, let me turn things over to Professor Harold Sackeim. Thank you.
Hello there. I'm Harold Sackeim from Columbia University. We've had some AV problems, so I didn't hear the introduction from Andy, but I'm sure I owe him a beer or two for being overly kind. I'm going to share my screen. And today I'm going to speak to you about the field of neuromodulation. That's a little bit like bringing coal to Newcastle, as this is one of the great centers of the world in neuromodulation. And Dr. Luchter has certainly been a pioneer in this area. But today, what I'm going to try and do is share with you my vision as to where this field is going. In terms of disclosures, I consult for wide-ranging brain stimulation industry, from invasive neurosurgical procedures to the non-invasive forms. And I've had long-standing relationships with the pharmaceutical industry as well, most recently in terms of the development of psychedelics. I'm the originator of magnetic seizure therapy, a form of ECT that is focally oriented, as well as focal electrically administered seizure therapy, FEAS. Both of these are undergoing international trials right now. I'm also hold patents for the titration in the current domain and the adjustment of current in ECT. The field of brain stimulation is exploding. This slide on the right represents the number of publications per year for 6 different technologies: transcranial magnetic stimulation, deep brain stimulation, transcranial electrical stimulation, ECT, vagus nerve stimulation, and transcranial focus ultrasound. What you can see is in 1990, there were 28 publications in the year on TMS. In last year, in 2022, there were 1776 publications. This growth is truly remarkable. And we have about 6,000 papers a year now coming out in the field of neuromodulation, an extraordinary increase in scientific output. This output has been matched by advances in the treatments of people. That if we look at, for instance, what indications have been approved for the FDA for the various brain stimulation technologies, what we see is with TMS that we have approvals not only for major depression, but now also for specifically anxious depression, use of TMS for cortical mapping in neurosurgery, treatment of migraine with aura, OCD, smoking cessation, and multiple different protocols for TMS administration. If we think more broadly and think about all of the brain stimulation technologies, including DBS, VNS, ECT, and so on, we have approvals across a vast number of neurological and psychiatric conditions. And this is all innovations that have occurred within the last couple of decades. Today, what I'd like to do is begin by giving you sort of my big picture prophecies. Where is all of this research going? Where's the field of neuromodulation heading? And in doing that, I'd like to talk briefly about 3 topics. One is going to be technological development. What's going to change in how we treat people? The second will be clinical target development. Who do we treat and why are we treating them? And the third will be the neuroscience question of what exactly it is that we're trying to treat. If there's time at the end of this talk, I'd also like to be a little bit more practical and give you sort of the top level view, my view, as to what is happening with TMS, ECT, and VNS. Where do we stand in the treatment of mood disorders, and what are the key clinical questions facing these technologies? Since for those of you who are Jewish, the high holy days are going to be here, I thought I would not only wish you a happy new year, but indicate that the Talmud said long ago that since the day that the Holy Temple was destroyed, prophecy has been given to the fools, and that's my role today, is to be the fool. Now, we can learn a lot from the advances that have already been made. And what I'd like to show now, and for those who are certainly not neurologists, is a typical example of the impact of deep brain stimulation to the subthalamic nucleus in terms of the movement disorders of Parkinson's disease. This video is of a man in whom the chest was set off, the coldness of the gate. He had a hard time turning around. This is the same individual a minute or 2 after turning DBS on.
That's pretty good. Yeah, go ahead and walk back one more time.
And what's profound about that demonstration, and this, by the way, that video was almost 20 years old, it's from Johns Hopkins, is that man who had that intervention in the subthalamic nucleus, the SDN, is likely having the same preservation of motor symptoms that he had with initial use of DBS. In other words, DBS has remarkable durability of benefit. What's also highly important about DBS is that where we're intervening is 2 subway stops down from the lesion. The lesion in DBS is in the substantia nigra. We don't have a symptom of that illness until 80% of the cells that produce dopamine in the substantia nigra are dead. And the rest of the time is the further degeneration of those cells. The brilliance of Benabid, who I think will be getting the Nobel Prize for this work, was inserting electrodes in the subthalamic nucleus, 2 subway stops down from the lesion, buzzing that at 120 times a second, and producing that incredible improvement in a complex motor phenomena. What's also highly instructive about this example from DBS is if we look at, and this is a slide of a single DBS lead, 2 are usually placed in the brain, 1 on each side. Each of these contacts in the original Medtronic's leads, there were 4 contacts on each lead. Each of those contacts were about 1.5 millimeters apart, and each of them were about 1.5 millimeters wide. You would have to empirically determine which of the 8 electrodes to pair in order to get that therapeutic effect. That the focality was such that if you had the wrong contacts, you could get depression or mania, and not the anti-Parkinsonian effect. So this is an example of exquisite focality in the brain, where intervening in a specific spot makes a huge difference in the lives of people. In our field of neuromodulation, we also have interventions like ECT, which have broad impact on neuronal populations. So, and focality in that context is a quite different story. Now, obviously, one of the problems with DBS is that it's surgical, and that we have to essentially put a hole in the skull and insert an electrode through healthy tissue in order to achieve this therapeutic end. The other lesson we know from the Parkinson's story is that there's essentially a chemical lesion in the brain in a specific spot. And the way we treat it is very much like the way we treat psychiatric disorders and all neurologic disorders. We give a systemic medication that goes everywhere. And I would argue often we're poisoning the rest of the body because it's hard for the drug to get through the blood-brain barrier. And to achieve sufficient levels in the brain, we have to have toxic levels elsewhere. And obviously complicating that circumstance is the fact that we bathe the whole brain in these molecules. And that Parkinson's is a great example, because when we give L-Dopa or any of the dopamine agonists, we worry about compulsions, we worry about inability to sleep, and we worry about all sorts of psychosis, all sorts of problems that come from the drugs going to where they shouldn't be. So clearly, one of the big problems we've had in our field is that we don't have a way of administering focal pharmacology. And this slide illustrates one approach to this problem. And in terms of disclosures, I'm an advisor to Cerebral Therapeutics and help develop their protocols now for the treatment of PTSD. What Cerebral Therapeutics has done is implant in the abdomen a pump tunneled under the skin to a catheter that enters the brain, is under MRI guidance sent to the floor of the lateral ventricle, and the floor of the lateral ventricle is the hippocampus and the amygdala. And it infuses drug through that pump 24/7. In the first study that was done with this technology, and the neurosurgeon Dan Abrams was really the inventor of this, we took patients with medial temporal lobe epilepsy who were refractory to all medications, who were not candidates for surgery, and we had them fail sodium valproate at megadoses, and then administered intraventricularly the same drug, sodium valproate, but at 1/10 the dose that they had failed orally, and got a 70% reduction in seizure frequency. 3 out of 5 became seizure-free. And the next step we've taken in this work is we've gone to DOD and are looking at patients with highly resistant PTSD as candidates, where again, we are thinking that if we can essentially focally reduce activity in the hippocampus and amygdala, then we'll have a salutary effect on the expression of PTSD. Now, obviously, both approaches, DBS and the use of a shunt through the brain to deliver drugs, have the problem that they're going to always be limited in extent to extreme cases and carry the risks of an invasive procedure inside the brain itself. And our field of neuromodulation, I think, is coming to the idea that we have two primary technological goals. One is the development of non-invasive focal drug delivery, and the other is non-invasive focal energy delivery. Can, for instance, we do TMS, but do it deep in the brain without impacting on surrounding tissue? Can we do non-invasive, in other words, DBS? In my own mind, we're probably going to be succeeding at the non-invasive focal drug delivery somewhat sooner than the energy delivery, but I'll quickly review for you efforts in both respects. Now, back in 2018, Raj Iran, who's an interventional neuroradiologist at Stanford, published in Neuron a revolutionary paper in which what he did is he took molecules, in this case propofol, and encapsulated them in a nanoparticle, administered the nanoparticle systemically, and used focus ultrasound to uncage the nanoparticle, the drug from the nanoparticle. And this was done in preclinical work. And he showed that essentially he got millimeter resolution in being able to shut off particular areas of the brain with propofol non-invasively. And obviously, this was a very striking demonstration. Now, this approach has been extended further. So 2 years later, in Nature Communications, a group showed that not only can they do the same thing, but they could use ultrasound in two different ways. In one way, they can use it as a magnet, so to speak, at one frequency to aggregate these nanoparticles, these encapsulated nanoparticles, to a specific spot in the brain, aggregate them, and they aggregate them in this particular experiment 1,300 times what would occur just with background levels of systemic administration. So you can concentrate the drug in a particular place and then uncage it in that place. Now, focus ultrasound can also be used to focally open the blood-brain barrier. That's another way to deliver drugs non-invasively, particular spots in the brain. And this particular type of approach is being really pursued aggressively in oncology, because essentially what we're now capable of doing is treating gliomas in the brain by opening the BBB in particular spots so that neurotoxins can enter and destroy the cancerous cells. This slide illustrates basically what you're doing often in here is you're coupling the ultrasound with microbubbles that you inject systemically, but they circulate to the brain, and you have those microbubbles vibrate, which locally opens the blood-brain barrier. And this was in work in Alzheimer's patients in the human, showing essentially that they got extremely focal opening of the blood-brain barrier, which is totally reversible. There are multiple different approaches to this problem of focal pharmacology, and this is another example. This is from Ned Kalin's group at Wisconsin, working non-human primate model. They show that they can make these primates very anxious by using the human intruder paradigm. And what they did was they used DREAD, designer receptors that are exclusively activated by designer drugs. So they infected a particular part of the amygdala, the dorsal amygdala, with a virus so that it would express a receptor that it never expressed in nature. They used low-dose clozapine then to shut down those particular cells in the dorsal amygdala and show that they could reduce the anxiety response to the human intruder. People obviously are going to wonder, are we going to be able to go around and change people's cells? And focused ultrasound has already shown in preclinical work that by opening the blood-brain barrier, it can be used to allow viral vectors into specific brain areas with high focality. What about directing energy to a spot without stimulating the surround? This illustration is from work that was quite revolutionary at the time. This is from Ed Boyden's lab at MIT. And Boyden, as an undergraduate, had worked with Dusseldorf at Stanford in developing optogenetics. Really, two quite brilliant individuals. Dusseldorf just got the Japan Prize for that invention. Here, what you see is Grossman in Boyden's lab was suggesting that if you had two sets of electrodes on the skull, on the outside, sort of like double ECT, and you had one stimulating at 1,000 hertz and the other stimulating at 1,010 hertz, a subtraction would occur at the overlap of the spatial fields of the electrical fields of these stimulation paradigms, and you would have a 10 hertz at that level. And they were able to selectively move whiskers in a mouse and selectively activate the hippocampus, again in the mouse, using this temporal interfering electric fields paradigm. And there, in fact, are now new companies that are developing just to do this. My own sense is that there are a number of bioengineering problems with this approach, so it's really uncertain what is going to happen with it. But we have several others. This is an example of a paper published in Brain Stimulation, journal I founded, where it is using what is now called sonothermogenetics, essentially a viral vector that changes cellular activity, conformations, and the use of ultrasound to take advantage of that. And this is from Hong Chen at WashU. And basically what she did was she targeted specific neurons. In this particular case, I think it was acetylcholine neurons in a specific area of the brain that they would express an ion channel that is sensitive to changes in temperature. And she used the focused ultrasound to produce that focal change in temperature to get these neurons to depolarize selectively. There are a variety of approaches, again, to the sending of energy to the brain. A lot of them are being played out in the rehabilitation space. It really is a case that we're in a position where we can make the blind see and the deaf hear and the paralyzed walk, often by stimulating in particular neuronal regions and sending energy to spots. Some of that is using nanoparticles as transducers, some of that are magnetically sensitive nanoparticles and so on. But perhaps the most revolutionary and still to be determined whether it's going to pan out is direct use of focal ultrasound as a method of essentially producing neuronal depolarization. Can essentially we do what TMS does, but do it far more focally and anywhere we want without impacting on the surround. And this is an example of a study from my colleague, Mark George, his group, one of the first attempts in the human where they were trying to focus on the thalamus, the anterior thalamus, to change pain thresholds in normal individuals. You could see those dots are the scatter that they got in the actual stimulation paradigms, where they wanted to go, where they actually went. So there's some improvement that can be done there. But they were successful in manipulating pain thresholds in the humans by focusing on changing activity in the thalamus. And that group right now has a big protocol going on, a sham control protocol in the treatment of anxiety disorders by targeting the amygdala. So what I hope I've done is given you some sense that yes, we are on the threshold of being able to do focal pharmacology. We may in the future be able to do focal energy transfer. And I believe both of those possibilities will revolutionize the practice of neuropsychiatry, both neurology and psychiatry. I also think that we have to think very hard about what our clinical targets are, who we treat and why. Basically, just like Benabid's modulation of the expression of Parkinson's disease did nothing for the fundamental cause of that illness, but changed the expression of the illness. That is my view of what we do in psychiatry and neurology overall, that very little that we do is fundamental to the course of illness, but most of what we do changes disease expression. And I think we have an opportunity to think differently, that many of our illnesses are, for instance, stress-induced illness. If people are exposed to a major trauma, only 25% will develop PTSD. Almost all patients with mood disorders have triggers for whether it's loss or other types of deprivations that trigger them, that these are incredibly stress-sensitive illnesses. And I'd like to illustrate those possibilities with a paper from Hala Hu's group in China. She was trained at Berkeley, but now is running a major lab in China that was published in Science several years ago. Dr. Hu developed a paradigm that I'm going to show here, where you can rank mice in terms of how competitive they are, socially dominant, how much effort they give, determination. So in that example that you just saw, one mouse pushed the other mouse out of a glass tube. Turns out that mice are incredibly reliable in their rankings in this way. Some mice are losers all the time, some mice are winners all the time. And it has nothing to do with weight, strength. It has a lot to do, we think, with effort, determination, grit. What this group did is they did single unit recordings from the medial dorsal prefrontal cortex in hundreds and hundreds of neurons of winners, as well as control regions and in losers, and identified the cells that were firing when mice were winning. She then infected those specific cells with a virus so that she could shut them down, again with a clozapine-like drug. And she showed that she could turn the winners instantly into losers by shutting those cells down. What she also did, if I can get this, yes, this video going, is she turned, this is again without light, so that you see the rank 3 on the right is going to be pushed out of this tube by the rank 1, who will always be that. Now she uses photostimulation, optogenetics, the Dusseldorf invention. You see the light going off. That light was put in the medial dorsal prefrontal cortex, and the intensity of laser that you needed for that effect was a function of how many ranks apart the mice were. But what's profound about this particular study was if you give the mice 6 experiences of brain stimulation-induced winning, half the mice become winners for life. You've changed them forever. And we've worked out what pathway was changed. It was a thalamic medial dorsal prefrontal cortex pathway. And this, I think, can set up some thoughts in terms of the future, that, for instance, my own view is that the last time we did anything to modify disease expression with fundamental impact on disease course was when we discovered the spirochete for syphilis. Otherwise, all we've been doing is essentially giving aspirin for fever. That learned resilience is something that can be induced, enhanced by stimulation techniques. And this obviously has implications for psychotherapy as well, that what the person is doing while we're stimulating them may make a huge difference. Just like in TMS with OCD, we challenge them with their fears or with in addictions with what they're addicted to, that we can marry the behavioral intervention with the brain intervention. And now we have to confront the possibility that brain stimulation interventions can alter various aspects of personality, character. That's essentially what we're after clinically and in terms of enhancing resilience. And by the way, Marty Seligman and the neuroscientists in that part of the world also believe that it's the medial dorsal prefrontal cortex that essentially is the site of learned control or the opposite, helplessness. But will we have the possibility to alter empathy, impulsivity, irritability, and so on? And obviously, that's going to raise a whole bunch of ethical questions and regulatory issues about cosmetic brain stimulation. The neuroscience development, and then we'll get on to the current forms of stimulation mood disorders. I was one of the advisors to NeuroPace when the first responsive brain stimulation approaches were developed, and they were based on essentially this representation here. What you see in the slide on the right is EEG, intracranial, patients having a spontaneous seizure. You can see that in the leads at the top. It's fairly focal. Electrical stimulation occurs at the second arrow, and that shuts off the seizure. Nowadays, we can determine that somebody's going to have a seizure well ahead of the occurrence of the seizure itself. And that's what the ARNet system is all about, is can we personalize the intervention for the seizure expression of that individual, and that seems to work. My viewpoint is that we will be able to do this for far more than just seizure phenomena, that we should be able to detect craving, flashbacks, hallucinations, agitation. And I'll give you one example of this and give you an illustration of how at least some of the work I'm doing in that area. This is from Casey Halpern. He used to be at Stanford, is now at Penn. He's the head of functional neurosurgery at Penn. And what Halpern's group did is they took animals, made them addicted to fatty sugar food, just like all of us, and found that in the animals that when they were craving the food, they put them in a circumstance where they were confronted with the food, but they couldn't eat it. Sort of like taking a kid to the candy store, not letting them have any. They got a spike in the nucleus accumbens of slow wave activity. They then did the same in people, humans with loss of control eating, binge eating disorder, hundreds of pounds overweight, who had failed surgical attempts like bariatric surgery, and found that they got the same signal in the nucleus accumbens during craving, and you can see that in these in two patients in the slide in the graphic at the right of each one. This big increase in slow wave activity, and then they stimulated to prevent when the craving signal essentially was being shown. They stimulated that area to interfere with it, and it turned out that was it seemed quite therapeutic, as both of the individuals lost hundreds of pounds of weight. My sense is that the brain contains many signals that are of incredible utility to us in the clinical world, but we lack access to them because it's a closed system. And what we're seeing, certainly in my journal, Brain Stimulation, we're seeing many more intracranial EEG papers coming from the neurosurgeons who are now recording all sorts of behavioral events with them. To go about that more systematically, one of the new companies actually just started this year, Neuro Insights, is planning to put sensors on the catheters that are used for the shunts that are used for increased intracranial pressure, of which 30,000 Americans get every year. And these are people in the context of traumatic brain injury that typically have sleep disturbance, often seizures, hallucinations, panic attacks, and so on. And there, the strategy is going to be, can we acquire much better signals inside the brain, use AI approaches to identify the signals that go with particular behavioral phenomena, and at the same time have external validators, sensors on the outside, whether it's EEG, motion detection, heart rate, whatever, to that we can use a much wider scale. And so what we will be treating, I think, will be these biomarkers. Okay. So that's a little bit on where I think our field is going. I'm just, I guess in the next 12 minutes or so, I'm going to give you a very quick top-level view of where I think stand right now with TMS, ECT, and if we have time, VNS. This is UCLA is one of the great TMS capitals of the world. really important work coming out of here. And so much of what I have to say may be, sort of reinforcing your own perspectives. I'm going to share with you data from the NeuroStar registry. I chair that registry. Scott Aronson's on it, Linda Carpenter, and all the other names here, Todd Hutton, Ken Page, and Scott West. And this is a registry that now contains over 15,000 patients. And it's certainly the largest registry in the world for any treatment of depression. But what's important about it particularly is that once a site joins a registry, every patient at the site is included. There's no cherry picking of the patients. So the outcomes are representative of patients in America receiving TMS and largely private practice. There are now 118 sites in this registry. Almost virtually all of them are private practice sites. And this is one of the first papers that came out of the registry a couple of years ago, essentially showing that the efficacy of TMS in major depressive disorder is profoundly better than what we thought it was as it was being developed. I was the senior author for both the O'Riordan study that got FDA approval for TMS, and then for the OpTMS study, which was industry independent to reinforce that approval. And in both studies, we had about a 15% remission rate at the end of the blinded sham control phases. And the reason that was clinically it mattered or significant was because the remission rate with sham was only 5%. But at the time, I wrote, this is sort of a really interesting technology, it has promise. But, coming from ECT, where we expect a 60, 65% remission rate, it had certain limitations. Now, if you look at this slide where we're talking about 5,000 people, let's say we go to the completer sample, people who've had at least 20 treatments. These are all comers, regardless of how they were treated. 65% response rate, 32% remission rate. That's profoundly, it's as good essentially as any of the drugs we had in STAR-D. Other things I want to point out, these are the same data now looking at age. At the top of each graph is the response rate, at the bottom is the remission rate. The response rate with TMS is twice the remission rate. That's where real progress is going to be made. The response rate is in the 60s, the remission rate's around 30%. In ECT, for instance, the remission and response rates are virtually the same. I think we can move that remission rate up to the response rate. And if we do, then overall the numbers are going to be very, very much ECT-like. And I'll show you some reason for that optimism. The other things that these data illustrate is that the efficacy goes up with age. That if there's any aging effect, it's positive. There's a little bit drop in the more than 80-year-old group, that's the extreme right, but those numbers are tiny. My own view is that TMS essentially is devoid of side effects. It has no interaction that we know of with pharmacotherapy. It's in many ways an ideal treatment in the elderly. And I think it's a mistake and an accident of history that it's been reserved for TRD, in part because of the cost and the practicality. But in things like assisted living facilities, and I've just received a brain stimulation, the first papers from end-of-life care, where TMS has exerted really, really quite profound and important effects. It is not just an antidepressant, and we certainly don't have time to get into, are there different spots that you need to stimulate for different types of depression, let alone anxiety disorders and so on. I'm quite a bit skeptical about that localization type of argument. These are some data that Todd Hutton was the first author on, published out of the registry this past year in Clinical Psychiatry, on a huge sample of individuals with anxious depression. And what you see here is the change in the anxiety scores on the GAD versus the change in scores in depression on the PHQ-9. They share no items in common, and yet they're highly coupled. If your depression gets better, your anxiety gets better, and so on. That, in my view, TMS is profoundly anxiolytic, and it's likely that we're going to see expansion of indications in that realm. These are data that are essentially in press right now on 7,215 TMS patients. And this is data showing you how many patients people get and what their outcomes are. On the left is the change in PHQ-9 scores, percentage reduction, and on the right are response rates and remission rates. Again, you see the twice the remission and twice the response to remission rate. But notice how lawful it is that as you go up to 36 sessions of treatment, you have this big increase in the efficacy of the treatment. Each of these groups differ significantly from the other. Then when you get to the people who get long courses, they show some drop off, but they're doing better than the people who've had short courses. Part of what is really striking about these data is now when we look at these same groups of individuals and we ask, how did they do during the course of treatment? What we're plotting here is a degree of improvement in the PHQ-9% per session. So what is the change in symptoms per session? What is the bang for the buck? In the first 10 TMS sessions, you can see all the groups that got at least 36, that got 36 or less treatments, averaged about 3% reduction of symptoms per session, or 30% over 10 sessions. Then after 10 sessions, there's this huge drop-off. And Andy Luchter is saying they're seeing the same thing here, that we're going from 3% to about 1%. And then it's constant. And so there's some adaptive change that occurs in TMS where the efficacy of the intervention is a third what it was the first 10 treatments. Now, in ECT, I would have expected this sort of thing because ECT raises the threshold for itself. Electrical dose relative to threshold is a driver of efficacy, particularly with unilateral. And some similar type of adaptive change I would think is occurring with TMS. And if we could figure out what that was and overcome it, whether we could overcome it by increases in stimulus intensity relative to motor threshold or number, whatever it is, that may accelerate, because if we could get back to the 3%, obviously we'd be giving a lot less TMS. The other thing which is noteworthy here is nobody in any of these groups shows a drop-off at the end. Thank you. There's no plateau in efficacy at the end. And so what that means is if we gave more TMS, it may be that we would get those responders into remitters. And that's exactly what happens if we look at the extended courses. We're converting a lot of responders into remitters by giving more and more TMS. So my view is that we probably stop TMS for insurance reasons, practical reasons, because we can't keep going to remission in lots of patients. And if we can accelerate it, then obviously we'll be in good stead. And this is just an illustration for Nolan Williams' work that he got an accelerated effect by giving more TMS in the same day. And essentially within 5 days, he could get this type of an effect. So we have to begin thinking, I think, more along those lines. And what is it that we're trying to accelerate? I only have a few minutes left, so I'm going to skip data on how durable is TMS and give you just a little bit of sense about ECT and where we're going, and that's where I'll end to take questions. Modern ECT, this is vastly improved but greatly underused. That's an editorial I had in JAMA Psychiatry a couple of years ago, and the reason is I'll illustrate this slide. When I entered the field, I wrote my first ECT protocol in 1979. It was funded in 79 by NIMH. At the time, the predominant treatment was sine wave interventions. Nobody knew how to dose it. The average time it took you to know your name, the day of the week where you were after the treatment was 8 hours for bilateral ECT and 6 hours for unilateral. Over half of patients had to stop ECT prematurely before they were well because the cognitive effects were didn't remember where their room was. They didn't recognize relatives. It was that intense. We introduced titration. The first patient to ever be titrated was in 1990 at Columbia, and the switch to brief pulse, and that reduced the orientation time for bilateral ECT to 45 minutes and to unilateral to 30 minutes. The introduction of ultra brief pulse, cutting the width of the pulse markedly, resulted in a 1/3 the recovery time that we had with the brief pulse. A remarkable effect, and I'll show you some further data on that. And now the FEAST and MST, these new, more targeted, spatially targeted interventions, they have another 40% improvement. We're just about getting to where you have with anesthesia alone. Why does it matter that the acute effects are so sensitive to how we stimulate, to the brain stimulation paradigms? Because the acute effects predict the long-term effects. That, in my own view, the disorientation you get after ECT acutely is a rapidly shrinking retrograde amnesia. And the only persistent effect of ECT, and that's the effect we demonstrated, is its effect on retrograde amnesia, and in particular for autobiographical information. That's what patients are upset about the most. And the longer it takes you to recover orientation following the treatment, the more retrograde amnesia. This has now been replicated multiple times by other groups and with MST and so on. And just to illustrate the point concretely, these are scores on amnesia for autobiographical information from a 300-item inventory we developed at Columbia that led to the short form, the one that most of the world is now using. But what we're looking at is inconsistency in memory with oneself. Normal controls were tested a month apart, and their inconsistency scores are standardized. They're about -1. If you got ultra brief right unilateral, 6 times threshold, you couldn't be told apart from normal controls 1 or 2 days after ECT. But if you got other positioning in the brain and other pulse widths, you had massive, these are in units of effect size. So the difference between right unilateral ultra brief and bilateral brief pulse is 2 large effect sizes. It's about 1.5, where a large effect is 0.8. So that gives you a sense of just, and these differences among the conditions last 6 months, if not forever. And where you stimulate in the brain, what the pathways are, and how you stimulate are determine the efficacy of the treatment as well. It's not just the cognitive effects. And this is from papers in the archives, almost 25 years now, showing that how you dose unilateral ECT markedly changes the efficacy of the treatment, and it is as good or exceeds that of high-dose bilateral ECT. Okay, clinical challenges in ECT. Basically, one of the clinical challenges is the same clinical challenge for TMS and for VNS. We have very little information in the field of what do you do when it's not working? What do you give these people when it doesn't work? And the other issue facing all of it, particularly if you work with treatment-resistant patients, is what about the durability? For instance, in TMS, we still lack a true relapse curve for this treatment. We can't, with all honesty, tell people how long is this thing going to last. These are data, believe it or not, these, as far as I know, is one of the only studies ever on treatment of the ECT non-responder. And this slide is 100 patients at Columbia who did not do well with different forms of ECT. We then gave them a second course of ECT, and as you can see on the right, the initial remitter rate was 76%. A week later, with no drugs, it was 60%. These are people who had not responded to ECT after 10 treatments. You could see that their Hamilton scores at the end of 10 in the graph are extremely high, but after 8, they're in remission. I think the same will probably apply to TMS. That was what I was applying before. These things are highly sensitive to dosage, number of treatments, and so on. How we can accelerate it will matter, but one of the very first things we have to think about is how much treatment we're giving and are we stopping too soon? I'll just end with a little discussion of relapse. This is from Declan McLaughlin's group in Ireland, showing that over time, from the 60s to today, the relapse rate with ECT has gotten worse. It's absolutely true. We have to give more treatments to get people well. When Lothar Kalinowski, who started ECT in America at my place, the Psychiatric Institute, he said the modal number of treatments to get a depressed patient well was 4 to 6. It then moved to 6 to 8, 8 to 10, 10 to 12. Now, we're giving many patients 18, 20 treatments. Likewise, the relapse rates have gone up because we're treating more and more resistant patients. And this is an illustration from that 2000 study in the archives. Medication-resistant patients study followed for a year after their ECT, getting all remitted patients. You can see that those that are medication resistant relapse at twice the rate of those who did not have adequate pharmacotherapy before ECT. So that's our dilemma. Just some words of wisdom. This is a paper in JAMA that we published a number of years ago, showing that if you add lithium to nortriptyline, you have much better success at relapse prevention post-ECT than if you gave nortriptyline alone. And this particular study, we gave placebo after ECT and had an 84% relapse rate in 6 months on placebo. One of my views is that if you're sick enough, certainly to come to ECT, lithium should be, there's much evidence supporting the use of lithium. And I'm thinking that the same thing should be thought about a lot of the people that are coming for TMS, that should be added to their regimens. Now, I'm going to stop here, but simply say we now have evidence that if you add, for instance, rescue ECT to a pharmacotherapy regimen that includes venlafaxine and lithium, then you can do even better, that there's no reason to keep these apart. And certainly one of the things I'd love to see is the use of TMS as a method for relapse prevention post-ECT. And so that is where I think I will end and take questions.
Well, first of all, thank you so much, Dr. Sackeim, for this presentation. I feel like we should have set out to give you 3 or 4 hours to cover all of this, because there really is so much here, and you've clearly had your hand in just about all of it. So what I wanted to do is just list off a few questions here. I know we have limited time, and there are quite a few of them. So let me find out something. Let me figure one out here. So in terms of big picture considerations, given that we're psychiatrists, or we are in the field of psychiatry, what ought to be our commitment to the field of neuromodulation as a whole versus the more narrow interventional psychiatry? I know that's a phrase that's thrown around from time to time. I think it's fallen out of favor, at least here. I know in the clinic here, we treat tinnitus, we treat chronic pain, a variety of other medical or neuropsychiatric conditions, in addition to, mood disorders. How do you see psychiatrists playing a role in the neuropsychiatric illnesses that interventional psychiatry, that neuromodulation can address, so that we can actually do justice to the treatment overall, as opposed to just narrowly focusing on the population of patients with mood disorders, psychotic disorders, et cetera?
I think that's a profound question that is going to be resolved by politics, as opposed to what should be the case. For example, I was a member of the APA task force on ECT and drafted the APA task force reports on the 1990 and the 2001, 2/3 I wrote those, and have lobbied forever that people who do ECT should be credentialed. They should, that's a specialty that you should have some, and American Psychiatric has fought that forever. And so it's the same issue is going to come up with neuromodulation, let alone should it expand across neurology and psychiatry, neurosurgery, and so on. That there is no special credentialing for psychopharmacology, right? That anybody with an MD can prescribe any drug. And so what should be the case and what will be the case may be two different things. And it's politics, because the APA's view is that the minute you have subspecialties, then you restrict who can do what. And so our members are not going to like that they won't be able to do that. From the point of view of the patient, I think obviously that's not a smart way to go. That there's enough specialty. What you can see happening here is the bioengineering, the neurophysiology, the anatomy, all of that stuff is coming together in a way that if you're really in the field of neuromodulation, you have a level of expertise that is very different than doing analysis, psychotherapy, or whatever. So that's one question. I think the interventional psychiatry question is largely a ketamine-driven question, because it's neuromodulation plus ketamine is what gives you. That's why Yale is big on interventional psychiatry. I just lectured in their interventional psychiatry program, because they're big on the ketamine. issue. So whether it's going to be defined by whether you're procedure-based as opposed to whether, the substance is going to be a whole issue. And then the final big issue is going to be, like there's a summit at Harvard next week that some of you will be attending, which is exactly on this question. Should there be subspecialties? And one of the big questions is going to be, is it going to be a subspecialty that spans our silos of neurology, neurosurgery, and psychiatry? It makes, I introduced the use of ECT to treat status epilepticus. And that's now, and I followed patients with epilepsy for several years at Columbia before the neurologist felt secure enough to allow us to do that with their patients. And so that, and Stan Fond, the guy of Parkinson's disease, who used to send us 20, 30 patients a year to treat with ECT because of their, so there's certainly a lot of background for where these disciplines can be treating together their same patients. And there's an intellectual need for that. But I also recall one of my first mentors and somebody who I respected greatly was Norm Geschwin. And Geschwin famously said that the borderland between psychiatry and neurology is more like a wasteland than a borderland.
I like that. I think we might have time for one more question. And this actually comes from Dr. Wilkie in the division. What is your view of combining TMS with pharmacological or behavioral/cognitive interventions? It seems like there should be opportunities to optimize the state of the brain in ways that enhance its response to existing brain stimulation modalities.
Yeah, I'm giving a seminar tomorrow on that topic, exactly, which is how do we stage and how do we combine neuromodulation and pharmacology? And one of the take-home notes is, I don't have any difficulty telling you what drugs you should combine with ECT and what drugs you shouldn't, right? What interferes with it and what helps it. And there's we did the only placebo-controlled trial in the modern era of randomizing people to antidepressants during ECT or placebo in hundreds of patients, and found that antidepressants improved the outcomes with ECT, right? Something that America had said you don't have to do, but it turns out that I also think that it's not just pharmacology that we need to learn about, but a good example is there's some work showing that you could use 20 minutes before an ECT session, give some TMS and lower the seizure threshold, that your dosing can be improved by use of TMS just beforehand. As I said before, there's no reason why we're not using TMS as a rescue treatment for people post-ECT. And we could talk about this with all the others, that there are ways of combining them that we have to really begin to think about.
Great. And here's one question that's really concrete. As an insider, how close are we to transcranial focused ultrasound in terms of clinical use? Years, decades?
I think we're years. I think that what you'll see is oncology will be the first. There's no doubt that we can locally open the blood-brain barrier, no doubt that we can have large molecules enter that couldn't enter before, and we could treat cancer. I think that's why I think focal pharmacology, it will revolutionize neurology and psychiatry. Who wouldn't want to see if we could tone down the anterior cingulate in a depressed patient? Who would? That's an obvious target. So I think the research will happen first, obviously, and then the clinical approvals, God knows how long that will take. But I think that revolution is on the way. I think it will take longer to do the energy transfer. But for instance, if the work that's being done, it's now at many labs across the world. If what Mark George is trying to do, which is use focused ultrasound essentially as a stimulation technique directly, and in his case, he wants to shut down the amygdala. If that pans out for anxiety disorders, then you're going to see incredibly fast uptake.
Well, hopefully it does pan out. I want to thank you again and thank everyone for attending. Really just such a privilege to have you here, Dr. Sackeim. A privilege for me as well. Your name was, I heard your name so frequently in the halls of PI where I trained, and it's a pleasure to finally make your acquaintance. And thanks to everybody again. And don't forget that tomorrow we have a seminar series at noon. I believe everybody should have received the information on that. And I hope everyone has a wonderful day.